Hi everyone, thank you for joining us today at our October Lunch and Learn. Today we have an obstetrician and gynecologist presenting on breast cancer awareness during Breast Cancer Awareness Month.
I'm Dr. Allison Khavkin. I'm an obstetrician and gynecologist at Good Shepherd, and I'm the medical director of the Women's Center here. I am doing a chat on breast cancer awareness for the month of October. So we'll get to the next slide. Breast cancer is the most frequent cause of non-skin cancer death in women worldwide. It's also the most commonly diagnosed cancer in US women and the second most frequent cause of cancer death in US women. The most frequent cause of cancer death in the US women is lung cancer. Breast cancer does account for 30% of all new cases of cancer diagnosed in women. In the US, a woman's lifetime risk of developing breast cancer is approximately 12% or 1 in 8. The majority of breast cancers in the US are diagnosed secondary to an abnormal screening study, although a significant number are first brought to attention by the patient themselves. And screening mammography both reduces the odds of dying of breast cancer and allows for early treatment. The current 5-year survival rate is 90%, which is substantially higher than it was in 1975 with a rate of 75%.
Look at her. You just use computer. Oh.
We'll go to the next slide. So the main risk factors for breast cancer are female sex. Of course, more than 99% of cases of breast cancer occur in women, and advancing age. And although other characteristics have been associated with an increased risk of breast cancer, most women in whom invasive breast cancer is diagnosed don't actually have any identifiable risk factors. So the risk factors are a family history of breast, ovarian, or other hereditary breast and ovarian syndrome associated cancers, a known deleterious gene mutation, prior breast biopsy that came back with atypical hyperplasia or lobular carcinoma in situ, menopausal hormone therapy with both estrogen and progestin, increasing age, certain ethnicities. So there is an increased risk for BRCA mutations in Ashkenazi Jewish population, higher BMI, alcohol consumption, smoking, dense breasts on mammography, and then prior exposure to high-dose therapeutic chest irradiation in young women between ages of 10 and 30. And go to the next slide. So there are certain reproductive factors that can influence breast cancer risk, particularly with the risk of hormone receptor positive breast cancer. Includes nulliparity, which means never being pregnant, early menarche, which is early start to having periods, late menopause, prolonged interval between menarche and then your first pregnancy, and not breastfeeding. And although there is no standardization about exact percentages of lifetime risk developing breast cancer within each risk category, generally it's understood that an average risk is under 15%, moderate is between 15 to 20%, and then high risk is over 20% lifetime risk of developing breast cancer. And women can be characterized for risk based on their history alone or using a risk prediction model that's available. We'll go to the next slide. So as I said, there's different breast cancer risk assessment tools. The most commonly used is called the Gale Model. It is available at the National Cancer Institute website. It's pretty easy to use. It is intended for women who have never had a diagnosis of breast cancer or ductal carcinoma in situ or lobular carcinoma in situ and do not have a strong family history. It does incorporate age, race and ethnicity, the history of breast disease, age of menarche, parity, and then family history. And it does calculate the risk of developing breast cancer before the age of 90, as well as within 5 years. There are limitations. The Gale model is less precise in older women or if they have a strong family history of breast or ovarian cancer. It's not useful if there is a strong family history of breast cancer on the paternal side. It's not as accurate for ethnicities other than white or black, just because it never was tested outside of those two. And then it doesn't consider the breast density or any pathogenic BRCA1 or 2 mutations. There are other validated assessment tools available online, including BRCA Pro, breast and ovarian analysis of disease incidence and carrier estimation algorithm, the International Breast Cancer Intervention Study, also known as TYRE-PUSIC, or the Claus model. We'll go to the next slide. So the goal of screening is to detect preclinical disease in healthy asymptomatic patients to prevent adverse outcomes, improve survival, and avoid the need for more intensive treatments. So screening tests have both benefits, like improved health outcomes, and adverse consequences. And that includes cost, anxiety, inconvenience, false positive results, overdiagnosis, and overtreatment. So there are varying judgments about the appropriate balance between the benefits and the harms. And that's why there's differences in recommendations from the major guideline group that you can see here on the slide. As an OBGYN, I do follow most closely to the American College of Obstetricians and Gynecologists recommendations. The most important being that we offer screening mammography starting at age 40. Mostly it is an annual kind of screening recommendation, but every 2 years is also an appropriate option. And it all comes down to making a shared decision on this treatment with the patient. And we'll go to the next slide. So for women in their 40s, the number who benefit from starting regular screening mammography is smaller, and the number experiencing harm is larger compared to older women. But for 40-year-old women, the benefits still outweigh the harms to a smaller degree, and therefore it is subject to more individual values and preferences than for older women. So as you can see in this slide, there's about 1 fewer breast cancer death per 1,000 women screened if they start at age 40 versus 50, and there is increased false positives and unnecessary breast biopsies. We'll go to the next slide. This shows the information between an annual and every 2-year mammography. So annual screening results in the least number of breast cancer deaths, particularly in younger women, but at the cost of additional callbacks and biopsies. So clinicians should initiate a discussion about the frequency of screening once a woman has decided to initiate the screening. Say a woman chooses annual screening, they may place a greater value on the potential for averting breast cancer death and then less value on the possible harms, versus a woman who maybe chooses biennial screening. They are more concerned about experiencing potential harms and less worried about a breast cancer death that could have been averted. Of course, a hybrid approach to screening where a woman maybe initially chooses annual screening and then decreases to biennial after the age of 55 is a reasonable option. And we'll go to the next slide. So the majority of women are of average risk, and therefore the most important factor in her decision about when to be screened is age. Mammography is less sensitive in younger rather than older women, and therefore there are more false positives. And there's not a clear upper age limit or ideal frequency for screening, as we've talked about. 75 years and older are offered screening only if their life expectancy is at least 10 years. However, I've had many patients who still decide they want to do annual screening because they would still want treatment if something were to come back abnormal. So therefore, it's important to ensure that shared decision-making occurs. Mammography is the primary modality for screening, but it still may miss up to 20% of underlying breast cancers. Ultrasound and MRI are reserved for further evaluation of abnormal findings on mammography or for screening of higher risk women. Breast exam is not recommended as the only screening method, and it's actually controversial as to whether clinician breast examination or patient breast self-examination are beneficial as an adjunct to mammography. Therefore, it is important to educate women about breast awareness and to encourage women to report any breast concerns. Next slide. So about breast self-awareness, it is defined as a woman's awareness of the normal appearance and feel of her breasts. It does not include a recommendation for women to examine their breasts in a systematic way or on a routine basis. But it is advised to notify their healthcare provider if they notice a change such as pain, mass, new onset of nipple discharge, or redness in their breasts. Because approximately 50% of breast cancer cases in women 50 years and older, as well as 71% of breast cancer cases in women younger than 50 are actually detected by women themselves. Next slide. So these last two slides are just about some special considerations for women who have had breast augmentation for benign, which means just cosmetic reasons. The indication and frequency of screening are the same as women without implants. The implants can obscure some small lesions, and it can make compression challenging. Of course, the type and location of the implant plays a role in the ease of imaging. So either the implant is above or below the muscle. For pregnancy and lactation, pregnant individuals should have their abdomens shielded. The hormone changes associated with pregnancy and lactation can cause a proliferation or increase in the ducts and lobules that result in increased density and nodularity of the breasts, and that can make it difficult to identify some small masses, asymmetries, and distortions, overall decreasing the sensitivity of mammography. Any palpable findings are usually examined with ultrasound. For males, routine mammography is not performed for most biological males. However, carriers of BRCA1 or 2 who also have maybe gynecomastia or a significant amount of breast tissue would also consider screening. The next slide. For patients with dense breast tissue, it does decrease the sensitivity of mammography for smaller lesions, and it is preferred to use digital mammography, which is typically what's used in most US locations. If there are no additional risk factors, there's no supplemental screening recommended. And many states have laws requiring that patients be informed about their breast density, including Oregon. Postmenopausal hormone therapy, it does increase the breast density and may decrease the sensitivity of mammography. However, there's still no change in the screening recommendations. Estrogen and progestin increased mammography breast density in the Women Health Initiative trial, but not when estrogen was used alone. And then lastly, about COVID-19. There can be axillary adenopathy, which is also lymph nodes, that has been reported after vaccination. And if possible, screening mammography should be scheduled prior to the first dose of receiving an mRNA vaccine or 4 to 6 weeks following the second dose. And the next slide is just about my sources. And that's all I have to say.